Today we're going to speak about such an important topic, a relatively difficult one, but also a really interesting one. So we'll be talking today about management of TGA, transposition of great arteries. So last time we've given an idea about what is TGA. So briefly we said TGA is transposition of great arteries. We mean D-transposition, which is AV concordance, BA discordance, and then you get two parallel circulations, which is a configuration which is not compatible with life, and so you have to have some mixing where some oxygenated blood will be able to go from pulmonary circulation that is going separate from the systemic, so some oxygenated blood will mix so that it goes to the systemic so that we can sustain life. Okay? And we said that 3 levels of mixing are there, which is at atrial level, ventricular level, or at the arterial level, the PDA. And so we said it's not a rare disease. It's actually the second most common cyanotic heart disease, and actually one of the diseases that has high mortality. We've given an idea about main association with transposition of great arteries, and these are there's high likelihood for patients with TGA to get a VSD, LVOT obstruction, maybe both, and some other abnormalities like arch anomalies, coronary anomalies, and things like that. These anomalies are very common to the extent that we put them into the algorithm of thinking how to manage TGA. They do affect a lot the pathophysiology, also the presentation and management of these cases. So today we want to say which patient will get which intervention, when, but also importantly why, so that we can think it over and get the different combinations. So we discussed that they have parallel circulation. So deoxygenated blood come back right atrium, right ventricle, aorta, come back to the systemic veins, and this is systemic circulation that keeps going like that, and another parallel circulation, oxygenated blood coming back to the left atrium, left ventricle, pulmonary arteries, and then they keep going. So patients with TGA by necessity have cyanosis, and this is because of the parallel circulation. This is not because the pulmonary blood flow is low, okay, which is very different from other diseases like Fallot. So patients with Fallot have cyanosis because of right to left shunt. So deoxygenated blood, instead of going to the lungs, will shunt through a VSD into the systemic circulation, and then the absolute amount of pulmonary blood flow is actually low. In these patients, cyanosis is because of the parallel circulation. So patients can have a really high pulmonary flow and still can be very cyanotic. So the treatment of these patients are not to increase the pulmonary blood flow more, because it's not low. Two of the sites of mixing that allow survival actually cause high pulmonary flow and high pulmonary pressure. So the patient can have a VSD or a PDA, and if these are large, the pulmonary flow will be actually quite high and pulmonary pressure will be high. So putting pulmonary hypertension into the context of the disease allows to think how to manage. Also the state of the LV conditioning or deconditioning. So in these patients, the left ventricle is exposed to the pulmonary circulation. And since the pulmonary vascular resistance is a lot lower than the systemic vascular resistance, so pulmonary artery pressure is a lot lower than systemic pressure, obviously provided that there is no big communication, no big VSD or PD. And then the LV will be exposed to low pressure. And if this continues, then the LV muscle mass will regress, and then it will be no longer able to sustain high pressures. So whatever operation that we do that then exposes LV to systemic pressure will not be tolerated. This LV deconditioning takes some time. So immediately after birth, the LV wall thickness is still high enough, big enough, because during the fetal circulation, the PA pressure is high. But then immediately after birth, there's still the pulmonary hypertension of the newborn, which takes a few weeks. And then during that period, the LV wall thickness will start to regress quickly unless there is other causes that keeps the LV either pressure or volume loaded. So we've talked about these things in the previous lecture. And quickly touch on natural history. So this is a fatal disease. 90% of TGA with intact ventricular septum die within the first year of life. And they present with profound cyanosis and circulatory collapse. On the other hand, patients with VSD are less cyanotic, but then they also quickly develop congestive heart failure and pulmonary vascular disease, and this happens a lot earlier than other lesions with the same size of VSD. So patients with TGA tend to develop pulmonary vascular disease a lot earlier than other patients who have the same size of the VSD. Again, we've discussed that thoroughly last time. So we want to talk about strategy. We have a patient who was newly born and he has a TGA. What do we do? So in simple TGA, so what is simple TGA? Simple TGA is a patient who has TGA and no other lesions, except those who are found in other normal newborns, which is a small PFO, which is closing, a small PDA, which is also closing. Okay? These are normally present during the fetal circulation, and then after birth, they tend to close. So these two sites are important sites of mixing. So they are essential for the survival of these patients. So we have to maintain these sites of mixing to be able to sustain life. So we will keep discussing in every category of the patients about these 3 points. The degree of cyanosis, does the patient have pulmonary hypertension or not, and the LV condition. Is it conditioned or start deconditioned? Which allows us to think about management. So again, all patients with TGA will have cyanosis, but then we speak about degree of cyanosis. So if a patient is a simple TGA, so TGA and nothing else, the two sites of mixing are starting to close. Do you think the cyanosis will be severe or less severe? Severe, okay? Because now the sites of mixing are starting to diminish. Does this patient have pulmonary hypertension? I mean, not like any newborn with a pulmonary hypertension newborn. I mean, does this sort of circulation allow big shunts and direct transmission of pressure into the pulmonary? No. So these patients do not have pulmonary hypertension as such, not like just like any newborn. And how about the condition of the LV? So immediately after birth, the LV is still conditioned, but then over the following days, the LV mass starts to regress quite quickly. When does that actually happen? So it is variable. It depends about the size of the ASD. We've discussed last time that the bigger the ASD, the quicker the deconditioning, because of the quick volume unloading of the LV. If there is any VSD or LV tube obstruction, but in this patient there is no VSD, there's no LV tube obstruction, so LV will start deconditioning quite quickly, and the LV stops being able to sustain systemic pressure, something like after 3 to 4 weeks. Okay. So what do we do now? So the main goal here is to keep the patient alive. Okay? He's newly born, very cyanotic. What do we do? Sorry?
Stabilize the patient first.
How? So let's step back. We do not necessarily know that this is a TGA. So if a newborn that presents with cyanosis, people will reflexively think about putting him on oxygen, which is very, very dangerous. Why? So we have two sites of mixing, which is the PFO, which start to close. How does the PFO close? By the pressure difference. So after birth, the pulmonary blood flow increases a lot, so the pulmonary venous return increases. So LA pressure will become higher than RA pressure, and the valve-like flap will actually be pushed to close the PFO. So the PFO closure is at first by the difference in pressure, and then with time it endothelializes and then shuts like that. On the other hand, so the closure of the PFO is a passive thing related to hemodynamics, while the PDA closure is an active process. How does the PDA close after birth? The response of the muscle in the ductus wall to inhaled oxygen. So when oxygen entered the lungs, then the muscle in the ductus arteriosus will contract, closing that, and it was kept open by prostaglandins coming from the placenta, and now this is no longer there after birth. So there's no prostaglandins, and there's more oxygen, and that's why the PDA closes. So we have to reverse these. Okay? So giving oxygen here is very dangerous. This patient is not lacking oxygen. It's just that the oxygenated blood is not able to go to the systemic circulation. Okay? So giving more oxygen will not deliver the oxygenated blood into the systemic circulation. On the other hand, it will close the site of mixing. So patients with TGA should not be given oxygen unless we make sure that there are other sites of mixing. Okay, so we have to maintain one of those two sites. How can we open one of these? So how can we actively open a closing ductus arteriosus? So giving prostaglandins. So this is like the prostaglandin analog. How do you give that?
IV.
By an IV line. So what's the level of experience you need to give prostin? Put a cannula. Huh? So this is actually quite an easy and a quick intervention to keep the duct open, and does not need a high level of experience. On the other hand, so what are the disadvantages of giving prostaglandins? So it does cause apnea. So if the baby is not ventilated, he actually might stop breathing and then need active mechanical ventilation, which is an important thing. On the other hand, giving prostaglandin to maintain duct patency in an IV line is not a reliable thing for a long time, because if that patient needs to transfer, if this area does not have the level of experience providing arterial switch operation, this patient needs to travel for a long distance, having IV line maintaining duct patency might not be very reliable. Okay, so this might be dangerous. So it is a quick thing, does not need a lot of experience, but not very reliable, and can cause the patient to get ventilated. How do we open an ASD? So there's no medication that can open an ASD. We need to actively make a communication through that. And this is done by the balloon atria septostomy, the Rtswitch procedure. So the Rtswitch procedure, so there's a catheter which has a balloon at its tip, and then this passes from the IVC, so either coming from a femoral vein or an umbilical vein, passing through the IVC across the PFO into the left atrium, and then this balloon inflated and quickly pulling on that balloon, causing a tear into the patent foramen ovale, creating a good communication and a good site of mixing at the level of the atrium. So this is the balloon atrial septostomy. This has caused a big transformation in the management of patients with TGA. Patients with TGA, a lot of them were very, very unstable, affecting the survival of these patients, and this maintained a lot of patients to be alive, to be able to have any next step. So should we do balloon atrial septostomy for everybody? Obviously, there are problems related to vascular access and things like that, but this is not the main problem. The other main problem here is having a big atrial communication causes the LV to decondition a lot quicker. So patients who had balloon atrial septostomy should be quickly scheduled for the next step, which requires the LV to stay conditioned. So the decision to use prostaglandin or balloon atrial septostomy depends upon the circumstances. How is the patient, is he stable or not? And is he ready for the a quick operation or not? So if the patient is at a center who is ready to do arterial switch operation, we usually do not do routine Rushmans. We'll just get him for surgery, and if he's very unstable, we may put him on prostaglandin for a few hours before the operation. On the other hand, if the patient is in an area that is quite remote, does not have the experience of doing something like the Rushkin, needs transfer, then put him on prostin first, do the Rushkin, and then being transferred into a hospital with the required experience. So now we've got a stable patient who is a simple TGA, and now he's also having an ASD, or a patient who is already born with a big ASD. So is that patient cyanotic?
Yes.
Yes, because he's TGA. Is he very cyanotic or less cyanotic? So less cyanotic. So we're talking about saturation of the 70s to 80s. Is he pulmonary hypertensive?
No.
No. How is the LV? Starting to decondition very quickly. Within the first few days, something up to 3-4 weeks. Why? So we've discussed that thoroughly last time. Opening a big ASD causes a lot of left to right shunts, and then this LV was not pressure loaded because of the low pulmonary vascular resistance, but was volume loaded. Opening an ASD causes a lot of blood to shunt, and then it will also be offloaded from the volume point of view. So it's neither pressure nor volume loaded. There's a lot more hemodynamics that we've discussed in the previous time, so we can discuss that later if you want. So if the patient still has a deconditioned LV, I'm just very roughly saying less than 3 weeks, but we need to actually define. This means the patient has still conditioned LV. Soha will give us a big idea about judging the conditioning and the deconditioning, and there are lots of factors here. Time is a big factor, but also presence of other, how big is the ASD, how big is the PDA, is there any LV obstruction or not, and the level of pulmonary pressure and volume load. So I'm just saying the patient is still conditioned, has still conditioned LV. What should we do? Arterial switch operation. What is that? So arterial switch operation is an operation where we switch the arteries back to the normal configuration. And so the ascending aorta and the MPA are transected above the roots. So, and then they switch over so that the ascending aorta gets connected to the left ventricle, while the main pulmonary artery gets connected to the right ventricle, so that deoxygenated blood coming from the right ventricle will go to the lungs, while oxygenated blood will go to the ascending aorta. Coronary arteries come from the aorta wherever it comes from. So if the ascending aorta was coming from the right ventricle, the coronaries will be coming from that route. which arise from the right ventricle. And so if we switch the arteries and we transect them above the root, the coronaries come from the root. So we'll have to switch these over. So again, we'll have to take out the coronaries from the root, switch them into the other root that is coming from the left ventricle. So the Rtswitch operation is switching the great arteries, switching the coronaries. And now, this LV gets subjected to systemic circulation. So it has to be able to sustain systemic pressures. What are the advantage and disadvantage of this operation? So it is normal physiology, and it is anatomical repair. Anatomical repair, I mean that the systemic circulation will be supported by the morphologic left ventricle. Okay, it was before supported by the right ventricle, and now after the operation, it becomes supported by the left ventricle, which has the best long-term outcome. On the other hand, this is a big operation, so it needs a lot of experience. A lot of experience for all teams. So surgeons, anesthetists, intensivists, nurses, perfusionists, everybody, cardiologists, everybody have to be very experienced, and it needs to be done in specialized centers. There is a risk of ischemia, coronary ischemia during that transfer. There is risk of bleeding. Patients are actually very small, and this is a big operation, so they need special care. But again, from all the options, this operation provides the best long-term outcome. So what if the patient presents late? So if he was not diagnosed, or actually kept stuck in an area where they do not do this operation, and after putting Prostin, the patient got ventilated, and after ventilation, he had chest infections, and now we're not able to transfer him, and things like that. So he presents after that period, so 2-3 months of age. What do we do then? What if we do the arterial switch operation? What will happen? LV will not be able to sustain systemic circulation. So if this, at that age, the systemic pressure is something like 70, 80 millimeter mercury, while the pulmonary pressure is like 20. And if you're used to lift weight of 20 kilograms, you'll not be able to just lift 80 kilograms acutely, and then you'll just fail. And this is what happens to the left ventricle. If you do arterial switch operation in a deconditioned left ventricle, the left ventricle will not be able to support this circulation and just will not come off bypass. So this patient will not be able to come out of operation without mechanical support. So what do we do then? So we have two options. One option is just to accept that fact and deal with it, that this ventricle is not able anymore to sustain this pressure. So we'll have to do another strategy. Or actually start retraining that ventricle. If that ventricle was no longer exposed to high pressure, we very gradually expose that ventricle to higher pressure till it gets trained. So this is the two-stage switch strategy. So this strategy was described in the 70s by Professor Yaqub. So the aim of this strategy is to expose the left ventricle to higher pressures, and then allow this ventricle to be exposed to that pressure for some time till it gets trained. I mean, gets more LV wall thickness, more muscle mass, and then it becomes ready to do that arterial switch operation. So how would we expose the left ventricle to higher pressure? By something like inducing pulmonary stenosis. We put a pulmonary artery band, which is just an artificial band that you wrap around the main pulmonary artery. Remember, the LV gives the main pulmonary artery. And then if you do pulmonary artery band and then you induce stenosis in that pulmonary artery, then the left ventricle will have to exert more pressure to be able to push that blood against that narrow band. And so we keep tightening that band till we get the pressure that we want. So how high would you want that pressure to be? I mean, systemic, less than systemic, higher than systemic. How high would you want that? So it cannot. That ventricle cannot tolerate systemic pressure. If it was able to tolerate systemic pressure, we would just have done the Rtswitch operation. So the LV pressure has to be lower than the systemic pressure, so that the LV will be able to tolerate that. But on the other hand, it has to be significantly higher than what we started with, so that it starts straining. So we usually want that LV pressure to be something like 2/3 the systemic pressure. So if the systemic pressure in these patients is 70, 80, we want the pressure there to be 50, 55 or so. Okay? So that it will be tolerated by a ventricle that had a pressure of 20 to 30, but then it should not fail. And then very gradually, patient will grow while the band will not grow. And so very gradually, the gradient across that band will increase. So in these patients, we do not want the gradient across the band to be very high, just like 30, 35 millimeter mercury. And that's enough. So what was the saturation of that patient before we started? Some in the 70s, huh? So, and why was that saturation? Because he's a TGA, so he had parallel circulation, some mixing across the ASD, but then the desaturation was because of the parallel circulation, okay? But the pulmonary flow was not low. Now we're actually decreasing also the pulmonary flow. There's now an ASD, and so the blood will find it more difficult to go across the LVOT because of the band. And so the blood will find it easier to just go to the other side and not go anymore into the pulmonary circulation. And so in addition to the parallel circulations, you also get lower pulmonary flow. And so the saturation will actually decrease further. You get the saturation in the 40s, 50s. And you cannot tolerate that for a few months. So you cannot just say, okay, now this ventricle will train, go out with a saturation of the 40s, and then stay for 3-4 months and come back. Patients might not tolerate that. So just remind me, why did we do the band? To train the LV. Did we aim to decrease the pulmonary pressure? The pulmonary pressure was already low. Did we aim to decrease pulmonary flow? No, this is just the side effect of the band. So the aim of the band was to train the LV. The side effect of putting that band is that the pulmonary flow will become low. So we'll just do something else to counteract that side effect. And this is putting a synthetic systemic to pulmonary artery shunt. So BT shunt, which is a modified BT shunt, is a communication, a synthetic shunt, communicating between the subclavian artery and the pulmonary artery. And so the blood coming out from the aorta will go from the subclavian artery into the pulmonary artery, increasing the amount of pulmonary blood flow and improving the saturation. So some would say you're doing two opposite operations at the same time. Do you want to increase pulmonary blood flow so you put a shunt, or do you want to decrease the pulmonary blood flow so you put a band? Why are you doing them both together? So we're not doing the pulmonary artery band to decrease pulmonary blood flow. We're putting a pulmonary artery band to train the LV. And then to counteract the side effect of the pulmonary artery band that causes decreasing pulmonary blood flow, we're actually doing a big shunt. Do you get that? Okay. So after doing this operation, you expect the LV to get training. The LV mass would increase. The pressure in that ventricle will be higher. And then you wait for a period. And after that, you reassess, is that left ventricle conditioned or not? And once that ventricle becomes conditioned, you do the arterial switch operation, and then take down the band and the shunt. No longer needed. Okay? And that's why we call that two-stage switch strategy. So we aim to reach the arterial switch operation, but then we need a first stage to prepare that ventricle to be able to tolerate that. how does the physiology of the patient improve after the first stage? So it does not improve. It does not improve. We're actually doing really two difficult procedures from the physiology standpoint of view. We have to balance these two procedures together so that there's enough pulmonary blood flow, there's enough saturation, the LV is not overwhelmed by the very high pressure caused by the band, and the shunt does not obstruct or close. Okay? And you have to wait on that situation for quite some time. Eventually, these patients will be able to do the arterial switch operation, but some patients will not be able to tolerate this stage. There's a considerable mortality after the first stage, and there's actually an interstage mortality. So even after patients come out of hospital, we're waiting for a few months till the left ventricle gets strained, and some patients might actually die outside. So although this has a happy ending, it is a really high risk strategy. And on the other hand, this cannot be an indefinite pathway, because the longer you wait, the left ventricle will not be able to become trained. So this has to be done early in life, because the results of starting to train the LV late in life is not good. What is late in life? So different studies have shown different results. The series of Professor Yaqub that was first described mentioned something like after 2 years of age. So if a patient comes like 3-4 years of age, the results of the late LV retraining is not good. So a lot of these patients will not tolerate training. Other studies have shown quite later age, but we know that the later you wait, the less probability that this LV will become really trained. And so what do we do if we're not able to go into this strategy? So just accept the fact that the LV will stay the pulmonary ventricle, and the right ventricle will be the systemic ventricle. So what are our problems here? So these patients have no pulmonary hypertension. The LV is deconditioned, and we have just accepted that. So now the problem is the cyanosis because of the parallel circulations. So if we're not able to switch the arteries, we switch the atria. So this ventricle will go to sleep on bypass. Then after the operation, will come back, finding itself pumping against the same circulation with the same pressure it is used to. But the very different thing is that the characteristic of blood inside it is very different. So we switch the atria, we direct the systemic venous blood to go into the left ventricle instead of going to the right ventricle. And so the systemic venous blood goes to the left ventricle, while pulmonary venous blood from behind it go into the right ventricle. So as if we switched the atria. If we're not able to switch arteries, we actually switch atria, and so you get AV discordance, VA discordance. And so deoxygenated blood will be pumped into the lungs, oxygenated blood will go into the aorta. So this is the atrial switch operation. There are two techniques to reach that configuration. The Senin was discovered first, then the mustard. There are two different techniques to reach the same configuration, where you get the systemic venous blood baffled into the left ventricle, which pumps blood into the pulmonary circulation, deoxygenated blood, getting back oxygenated blood into the pulmonary veins that will wrap around and go into the right ventricle to get pumped into the aorta. So will that, in this configuration, how are the circulations running? Are they running in parallel or in series? In series. So what's the saturation in the aorta here? It's 100%. What is the QPQS? 1. So this is normal physiology. So what's the difference here? The main difference here is that the right ventricle will remain the systemic ventricle. And we've seen that the right ventricle is not able to sustain that forever. Different reasons. Some reasons which are anatomical and geometry of the ventricle. So the LV has 3 muscle layers, one of them spiral. So the LV is designed to be able to sustain high pressures, while the right ventricle does not have that spiral. Actually have a moderator band that pushes the free wall against the septum. The design of the geometry of the tricuspid valve, which wants to be like a crescent rather than rounded. Other factors which are molecular, other factors that are hemodynamic. So for what we know that right ventricle might not be able to sustain high pressures for very long times. So the long-term outcome of the atrial switch is not as good as the arterial switch because of the failure of the systemic right ventricle.
When it will fail, septis, focus.
Again, very different. I'll show long-term outcome for these patients. They are not as bad as people thought, but they are not as good as the arterial switch. So we're talking about after 20 years of follow-up, 87% of patients are alive, and most of them, 90% of them, are free from reoperations. While in the arterial switch, survival is something like 96%. So it's better, but not a disaster. Okay, in the atrial switch. This is definitely a whole lot better than the natural history of the disease. Natural history of the disease is 90% with TGA intact septum die within the first year. So this is a big difference, and it made a whole revolution for the treatment of TGA in the 60s, where they were not able to do arterial switch back then, and actually the Senning was the first operation to be described, resulting in total repair with normal physiology, transforming the natural history of the disease from 90% mortality in the first year to 87% survival after 20 years. That's a big transformation. So whenever we get deconditioned LV, we start to get not perfect results. So we aim not to reach that stage. So we work very hard to do the arterial switch operation early on before LV deconditioning. Once it deconditions, then the outcomes are not great. So patient with simple TGA, we have to stabilize the patient. Do not give oxygen unless there's good ASD. And then we have to maintain sites of mixing, either through duct patency with prostaglandins or opening an ASD with a balloon atrial septostomy. If we're able to do arterial switch, we just go with that and do not wait. Once the patient gets deconditioned, now we have one of two options of retraining the ventricle, which is a higher risk strategy, eventually ending into arterial switch operation, or doing an atrial switch operation. Okay. We will be talking about different strategies with different options. Whenever you have questions, please ask, because okay, go ahead.
التايمنج بتاع ال3 اسابيع او معتمد على التايمنج بس العمر ولا في برضه بيجي لي فانكشن؟
So the question is that a solid date? Do any patient after does any patient after 3 weeks of age becomes deconditioned? No. I'm just oversimplifying things, but I mean here LV conditioned or deconditioned, or just mentioning dates so that we keep remembering them. But there are many factors for LV conditioning, depending on size of the ASD, size of the PDA, if there is any LV tube obstruction or any VSD, any pulmonary hypertension, and so many factors. But the age is one of the big factors here. So we've seen patients who are 2 months of age with very restrictive ASD, and they were still conditioned. But these are exceptions. Or had a slightly bigger PDA on their own, so they actually had pressure and volume load because of the PDA. So
Regarding the two strategies in late presenter
Yeah.
patients, what strategy do you prefer?
So we were very enthusiastic about the first stage. We did that a lot, and then we have seen not an ideal outcome with some mortalities after the first stage, and then we've started doing more and more atrial switch. So if a patient presents really late, like after 1.5 or 2 years or more, we just don't think, we just do the atrial switch operation. Other factors might let us choose one or the other. So if the patient already presents with moderate pulmonary regurg, and then after doing the arterial switch operation, this pulmonary valve will become aortic valve. And then we go through that very difficult high-risk strategy to eventually end up with less than ideal arterial switch, because the patient will already have considerable aortic regurg. So we just do not do that. On the other hand, some patients present already the first presentation with severely impaired right ventricle with a lot of tricuspid regurg. And so in these patients, even they are quite young. So in these patients, we do not want to end up with atrial switch with already failing systemic right ventricle. And so we're more inclined towards the other situation. So age is a factor, but also other anatomic factors. We're currently more inclined doing atrial switch operation and trying to improve the outcomes of that. We'll talk about that later. So we're more and more going away from the two-stage operation towards the atrial switch. So patients with TGA VSD, and I mean a big VSD. So if a patient has a like 2 millimeter VSD, which is not causing a lot of pressure transmission and so insignificant VSD, will just be treated like the previous scenario. But now we're talking about patients who have unrestricted VSD. So will these patients have cyanosis? Yes, because he's TGA. Do you think the cyanosis is severe or less severe? Less severe. So most of patients with large VSD will have less severe, because this is one site of mixing, but also they have very high pulmonary flow, and then a lot of that blood is loaded with oxygen, so some blood will be able to cross over and get into the system. But on the other hand, some patients will have a really big effect of streaming. So streaming is that you have two streams of blood that are not physically separated, but then they eventually separate with different characteristics. So blood that comes into the LV predominantly oxygenated will go very quickly into the pulmonary artery, while that blood in the RV in systole gets pushed into the aorta, and then you still get different saturation in aorta and pulmonary. So some patients, although having considerable sized VSD, may present with very severe cyanosis, and they actually improve a lot with doing a balloon atrial septostomy. And then you get surprised, because the ASD is really smaller than the VSD, but then there's enough time in the atria when during systole where the blood will be able to mix freely into the atria. So the best site of mixing is at the level of the ASD rather than the VSD. So as a very general rule, patients with VSD are less cyanotic, but do not get surprised if a patient presents with actually real cyanosis in spite of having a big VSD because of the streaming. So would this patient be pulmonary hypertensive? Yes, because now there's a big communication between both ventricles, and so there's direct transmission of pressure from the right ventricle to the left ventricle to the pulmonary arteries. So during systole, pressure in the aorta, RV, LV, and pulmonary artery will all almost be the same. Okay, so these patients have pulmonary hypertension with very high pulmonary flow. How is the LV condition? Because it is directly subjected to systemic pressure. So we're not afraid here that the LV gets deconditioned quickly, because it is already conditioned by the high pressure and the high volume of blood going into the lungs coming back to the left atria. So what do we do here? Arterial switch operation and VSD closure. So Do we have to do that very quickly before 3 weeks? So if a patient presents like 4, 5 months of age, you just go ahead and do the Rtswitch operation and VSD closure. But notice that these patients are more likely to develop congestive heart failure and early pulmonary vascular disease. So if a patient presents early, 2nd, 3rd week of life, we just go ahead and do the Rtswitch operation and VSD closure. You do not wait for these to develop. So again, very, very roughly, I'm just saying like less than 1 year of age. I mean before developing irreversible pulmonary vascular disease. So you just do the Rtswitch operation and prognosis worsens with increasing age because patients do not develop pulmonary vascular disease overnight. The more you stay, the more probability that parts of the pulmonary vascular bed will become affected. So we want to do that operation early so that you reverse this process earlier. What if the patient presents late? So a patient with TGA, large VSD, presenting at 1.5 years of age. What would you do then? So we know that these patients have a higher likelihood to develop pulmonary vascular disease a lot earlier. And so we have to make sure that this patient is not an Eisenmenger. Because if you have pulmonary vascular disease and you close the VSD, the pulmonary ventricle will fail. So for late presenters, we have to make sure that the pulmonary vascular resistance is still low and is reversible. And it does respond to oxygen, and we can see that there's increasing flow when we give pulmonary vasodilators. So if the patient is still reversible, not Eisenmenger, we still do that, arterial switch operation, VSD closure, acknowledging that this is a higher risk strategy because he has got some form of pulmonary vascular disease. Not Eisenmenger yet, but still later. What if he's already established Eisenmenger? So now this LV is pumping blood against the pulmonary artery, and this patient has developed irreversible increase in pulmonary vascular resistance. So that the pulmonary vascular resistance is very high, and now the shunt starts reversing, and the absolute amount of pulmonary blood flow starts to decrease. So patients with large VSD with normally connected heart, they're not TGA. If they develop Eisenmenger syndrome, we cannot close the VSD. So if you close the VSD, the pulmonary ventricle will fail. So in the normally connected heart, the right ventricle will fail because it will have to push blood against very, very high resistance. It used to push the blood across the VSD to pop off. But now if you close that, the pulmonary ventricle will fail. What would we do in a patient with a TGA and Eisenmenger? What's the saturation in a patient who is TGA with a VSD in the 80s? What's the saturation if the pulmonary blood flow decreases? Can go very, very low, 50s, 60s, sometimes 40s. So in addition to the parallel circulation causing the cyanosis, they also get low pulmonary flow. And then the oxygen saturation really drops. On the other hand, if a patient has Eisenmenger syndrome and he's not TGA, what's the oxygen saturation here? High 80s to 90s. Okay, obviously they have low functional capacity and less survival, but the saturation is a lot higher. What's the actually survival in the Eisenmenger syndrome who are not TGA? So patients with a big VSD diagnosed Eisenmenger syndrome. What would be the survival in these patients? The median survival is 20 years after the diagnosis of the Eisenmenger syndrome. So something like half of the patients will live longer than 20 years. What do you expect the survival of a patient who is living with a saturation of 40? A whole lot less. So the aim here is to transform a patient who is TGA Eisenmenger to become an Eisenmenger and not TGA. So you treat the TGA and leave the VSD open. So we do a palliative atrial switch. What do we mean by that? So we do an atrial switch so that deoxygenated blood will go to the left ventricle, pump to the pulmonary. Oxygenated blood coming from the left atrium into the right ventricle, into the aorta. So the oxygen saturation in the aorta will become a lot higher because most of the blood going into the aorta is coming from the pulmonary veins. And then you leave the VSD open. And so patients have a whole transformation of symptoms, going from saturation of the 40s, 50s into high 80s, 90s. Okay? So what do we mean by palliative? Palliative, that we mean that we're not doing a total correction. We're not closing the VSD. We're leaving the VSD open. We're transforming a TGA VSD, a TGA Eisenmenger, to become an Eisenmenger which is not TGA. Okay? We've been exploring with these patients and then starting to narrow the VSD because we've seen some of them actually gets dropping in the pulmonary vascular resistance and high pulmonary flow, but that's another thing. So patients with TGA and Eisenmenger, irreversible increase in pulmonary vascular disease, we do palliative atrial switch. So why not palliative arterial switch? Why don't we just do the arterial switch? That's another way of fixing. It's a much bigger operation. And what's the advantage of arterial switch over the atrial switch? The long-term outcome. We're obviously limited here by the Eisenmenger syndrome. So we're not talking about long-term outcome. We're talking about palliation. So let's do the easier operation, the less risky on the short term, improve the symptoms, do not subject them to risks of ischemia and bleeding, and we just get out of the operation with better saturation, improve the symptoms, and that's it. Okay? So patients with simple TGA, stabilize the patient, maybe Prostin, maybe Rushkent, then do early arterial switch operation before LV deconditioning. If patients present with deconditioned LV with TG intact septum, you then start thinking about either doing a two-stage operation, band and shunt, followed by arterial switch, or atrial switch operation, which has the risk of failing systemic right ventricle later on. If a patient presents with TGA and large VSD, you just go on and do the operation, arterial switch operation with the VSD closure, provided that the patient has no pulmonary vascular disease. If he has pulmonary vascular disease, we have to check if that reversible or irreversible. If it is still reversible, we do the arterial switch, and then that's a higher risk. If it is irreversible, which is established Eisenmenger syndrome, we then correct the TGA and leave the VSD, so we do palliative atrial switch operation. Are you still with me? You have not there. Okay.
Regarding those patients below 1 year,
Yes?
if there is a rule for diagnostic CAS before arterial switch, or
It's very unlikely. Again, when I say 1 year and more than less than 1 year and more than 1 year, this is really oversimplification. So I'm just saying here, do you have the diagnosis of Eisenmenger syndrome or not? The age is one factor, the cath is another factor, but all sorts of things. The size of the heart, the X-ray, the degree of shunting across the VSD, what's the oxygen saturation. So the whole spectrum of how you diagnose Eisenmenger syndrome.
Yeah.
Again, here we're just oversimplifying so that we don't get lost with all the strategies. Do you have any other questions? Shall I continue? The coming is more difficult, so are you good? TGA, VSD, and LVOT obstruction. So now we're talking about obstruction to flow from the LV to the pulmonary circulation. So this is as if we're saying TGA, VSD, PS. So LVOT obstruction here, in the context of TGA, is obstruction to flow into the pulmonary circulation. So what can cause LVOT obstruction in a TGA? Again, we discussed that last time. So it can be valvular, subvalvular, can be good annulus but fused commissures, or can be subvalvular, which can be anything from posterior deviation of coronary septum, can be muscle, can be ridge, something like the subaortic membrane will be subpulmonary membrane here. Dynamic obstruction, maybe accessory tissues from the mitral or the tricuspid sitting in there. So a whole sorts of accessory tissue tag or cords attached to the septum. So anything, but importantly, the pulmonary valve itself can actually be very small. Okay. So would these patients be cyanotic or less cyanotic? Severely cyanosed, because in addition to the parallel circulation, they also have very low pulmonary flow. Obviously, unless the pulmonary stenosis is not severe. So if it's mild to moderate stenosis, there will be more blood flow because of the VSD. But we'll just assume that the stenosis here is significant. So these patients will be considerably cyanosed. Will they have pulmonary hypertension? No, because they are protected by the pulmonary stenosis. So now the pulmonary vascular bed is not exposed to high pressures, high systemic pressures, not like the patients with VSD without LV obstruction. So they are not pulmonary hypertensive. How is the LV? Would you expect the LV to decondition quickly? No. Why? It is exposed to systemic pressure, and it's actually facing obstruction. So LV is conditioned. So what do we do here? We do Rtswitch operation. So if you do arterial and obviously VSD closure. So if you close the VSD and do Rtswitch, the severe pulmonary stenosis becomes severe aortic stenosis, and you cannot accept that. You cannot do a Rtswitch operation and come out with severe aortic stenosis. Okay? Obviously, if this obstruction is because of a resectable thing, so patients with subaortic membrane, you just excite the subaortic membrane. So if you have a membrane here, you just excite it. If you have a muscle called a septum, which is causing obstruction just beneath the valve, you can excise a bit of muscle ridge. But what if the obstruction is not resectable? So we're talking about resectable LV obstruction, and then you would do resection, arterial switch, and VSD closure. So what if the obstruction is irresectable? Let's assume that the pulmonary valve annulus is very small. And so the whole pulmonary valve is very small. Whatever you do, commissurotomy or anything, you're just left with severely stenotic valve. If you close the VSD and do arterial switch, you get severe aortic stenosis, which you cannot accept. When do we do that? We close the VSD. Instead of closing the VSD this way, we close the VSD that way. And so we direct LV into the aorta, borrowing a track inside the RV. So the blood coming from the LV will go through VSD into a baffle inside the RV to come out of aorta. And then we close the pulmonary valve. So now the patient will have an LV that is communicating with aorta. Now the RV has no outlet, and the pulmonary circulation has no inflow. And then you put an RV to PA conduit. So you end up with an intracardiac baffle from LV through the VSD to the aorta, an extracardiac conduit from the RV to the pulmonary circulation. So this is the Rastelli operation. So the Rastelli is the guy who described this operation, where you get intracardiac tunnel from the LV through the VSD to the aorta, and from an extracardiac conduit from RV into the pulmonary artery. And so you're doing a ventricular repair, as opposed to the arterial switch was an arterial repair, the atrial switch as an atrial repair, and now you get a ventricular repair, something like the rest. So let's assume a patient presents at 1 week of age, very, very cyanotic, has a TGA VSDPS with severe hypoplasia of the pulmonary valve annulus. So we do we go in, do the operation, we do Rastelli operation. Okay. What would you expect the size of the conduit to be? So he's 1 week of age, like 2.5 kilos. And now we want to put a conduit from the RV to the pulmonary. What would you expect the size to be? Very, very small. And then when the patient gets to a 1 year of age, he's like 9-10 kilos. So he has tripled his body weight, while this conduit will not grow. So the patient is growing very fast, while the conduit is not growing. Actually, if this conduit has any biological valve, which we usually do, so this valve will calcify. And then when they calcify, they become stenotic. So the patient will grow, and actually the conduit becomes smaller. So you go in and change that conduit. Okay, replace it, put a bigger size conduit. And then when he's 3 years of age, it becomes smaller, and then you have to replace it. And then 7 years of age, and then 10 years of age. You keep doing like that. And then these are big operations and actually quite risky. Also, the tunnel of the LV into the aorta, you have done that tunnel when the patient was 2-3 kilos. And then this tunnel has a big size of the circumference as a synthetic patch. And this patch will not grow. So you also get LV obstruction. So in one of these operations, you'll have to redo the whole operation. You'll have to get a bigger LV to PA tunnel, but also a bigger RV to PA conduit. So what's actually the current problem of this patient who is 1 week of age? Do you expect him to develop pulmonary hypertension with age? No, he's protected. Do you expect if you wait that the LV will become deconditioned? No. So the major problem now is the severe cyanosis. So we just aim to improve the cyanosis, let him grow, and when the patient grows older, we'll be able to put a bigger size conduit. And then the risks of developing LVOT and RVT obstructions becomes a lot less. So we very simply just do a BT shunt. So we do a systemic to pulmonary artery shunt, which improves the saturation, let the patient grow older, and then when he's like 5-7 years of age, then we'll be able to put a much bigger conduit, bigger than the patient would actually have. So if like a patient is 7 years of age and then he has like 14 millimeter, 15 millimeter pulmonary artery ideal size, we'd actually put something like 20-22 conduit. And then the size of the chest will adapt bigger conduits, while very tiny babies, 2-3 kilos, they do not adapt bigger size conduits. Okay? And so the patient will grow older and the conduit gets smaller and he can still tolerate that for quite a long time. And then at that size valves, he would be able to do percutaneous valves later on. So again, we have this option with bigger conduits. On the other hand, if the baby is very small with very tiny conduit, percutaneous replacement will not be an option. So we tend with these patients to wait so that they grow older, so that when we put conduits, they are bigger. And if they have very severe cyanosis, we may have to do a BT shunt earlier. And then when he is big enough, we can do the Rastelli. Okay? Are you with me? Do you get the idea of the Rastelli? So the Rastelli is intraventricular repair, where you direct the blood from the LV through the VSD to the aorta. So the VSD has to be big enough. If the VSD is small, it will actually cause LVH obstruction, subaortic stenosis. So the blood coming from the LV will be obstructed. So the VSD has to be big enough. It has to be just below the aorta. So if the VSD is apical, or if the tricuspid valve is in the way, you'll not be able to do such an operation. Okay? And then we're also limited by the limitations of the RV to PA conduit. So another option here is to do aortic root translocation, which was first described by Anechoid. So do you remember when we do the arterial switch. We transected the aorta and pulmonary arteries above the roots, and then we switched these over. In the aortic root translocation, you actually take out the aortic root from the ventricle and translocate that to be above the LV. So you take out the whole aortic root from the RV and actually translocate that over into the LV. And so you get something like that. Obviously, the pulmonary valve is very small, so we have to excise that. The pulmonary annulus might be very small, a lot smaller than the aortic valve. Then you actually open the coronal septum and put that and use the VSD to get the rest of the size of the annulus. So we'll be able to put bigger roots in that small annulus because you actually enlarge the annulus. So you would expect here that the risk of LV obstruction is a lot less because the blood does not have to go through the VSD into a tunnel in the RV to go to the aorta like the Rastelli. While on the other hand, you have to translocate the whole root, which is a big operation. This aortic root has coronaries connected to it, so you have to make sure that the coronaries are not kinked or stenotic. And then we'll have to connect the pulmonary artery into the RV with some sort of another. So maybe still RV to PA conduit, or maybe get the pulmonary bifurcation directly into the RV without a valve. So whatever configuration that we connect the RV to the pulmonary. So now we talk about, okay, that's the last entity, okay? So rest assured. So now we have to have a VSD to direct the blood from LV through that VSD in the Rastelli to the aorta. What if there's no VSD? So in the entity of TGA with LV obstruction without having a VSD. So would that patient be cyanotic? Yes, again, very cyanotic, parallel circulation and low pulmonary flow. Would the patient have pulmonary hypertension? No, because again, at first, the pulmonary circulation is not subjected anyway to the systemic circulation. There's no VSD. But also because the pulmonary stenosis is decreasing the pulmonary flow so that the blood will escape from the ASD. And how about the LV? Would be conditioned. Why is it conditioned? Because it is subjected to high pressure because of the effect of the LV obstruction. So what do we do then? We have actually to differentiate here between two big entities. Is that LV obstruction dynamic or fixed? What is dynamic LV obstruction? So dynamic LV obstruction is LV obstruction caused by hemodynamics. So the LVOT itself is not narrow. So the hemodynamics caused the LV to become narrow. What's the very famous example of dynamic LV obstruction that you know about? The systolic anterior motion, the SAM, systolic anterior motion. And where does that happen? In the HOCA, hypertrophic obstructive cardiomyopathy. So let's get back. We're not talking about TGA now. We're talking about HOCA. So left atrium, left ventricle aorta, so blood is going unobstructed. And then in the hypertrophic obstructive cardiomyopathy, the septum is very thick. And so the interventricular septum comes quite near to the anterior mitral leaflet. And so the blood going in between, in systole, causes Venturi effect. So it actually pulls back the anterior mitral leaflet into the LVOT, causing anterior motion of that anterior mitral leaflet. And so the anterior mitral leaflet will sit in the LVOT, causing severe LV obstruction. The LVOT itself is not narrow. It's just because this septum has come very near to the anterior mitral leaflet, causing the Venturi effect with the systolic anterior motion. Do you think it makes any difference for the anterior mitral leaflet that the septum came near to it because the septum is thick or the septum is pushed. The antimitral leaflet will find the septum coming near to it. It'll just have its right to do a systolic anterior motion because of the Venturi effect. This is what actually happens in the TGA. So in some patients of TGA, again, this is not very common, but this entity is there. Let's assume that this is a TGA. Left atrium, left ventricle, pulmonary artery. And then on the other side is the right ventricle. So which ventricle has higher pressure? Right ventricle, because it's exposed to systemic pressure. And so the septum actually can be pushed so that it comes near enough to the antemitral leaflet to cause systolic anterior motion. And then you get dynamic LVT obstruction. The LVOT itself is not narrow. The septum is just pushed. If you open the LVOT in an empty heart, you'll find the LVOT is actually quite wide. It is narrow because the septum is pushed from that side, then getting systolic anterior motion of the mitral, causing LVOT obstruction. Can be significant obstruction. Gradients can reach 80, 90, 100, something like that. And then if this ventricle is exposed to that high pressure of the LVT obstruction, it gets conditioned. So the LV wall gets good enough, and the LV mass will remain adequate. What would we do then? Arterial switch operation. What do we do for the LVT obstruction? We do nothing. So just doing arterial switch operation will get the pressure in the RV a lot lower, because now the RV pressure will be the pulmonary pressure, which is low, while the systemic pressure will be exposed to the left ventricle. So the pressure in the LV will be higher, and now you get the septum pushed towards the other side. There's no Venturi effect, no systolic anterior motion. The anterior mitral leaflet gets away from the septum, and the LVOT gets clear. We've got patients who are 10 years of age with no previous operation, had dynamic LVT obstruction, arterial switch operation, and they went home. So this entity is not very common, but it is there. If the patient has LVT obstruction, we have to check, is that a dynamic or a fixed obstruction? Okay. What if the LVT obstruction is actually fixed? So now the pulmonary valve is small. Again, resectable or resectable. If resectable, we do a resection and arterial switch operation. So if the obstruction is because of membrane, we just excite that membrane. If that's because of accessory mitral tissue, that we're absolutely sure that this is not contributing to the mitral valve action, so we excise the accessory tissue and then do the arterial switch. But then, if that obstruction is actually irresectable, so actually small pulmonary valve. Now we're getting into a difficult area, okay? Some people might be able to do Nikaido without a VSD, and then cut across the crest of the septum from above. Other option would just forget about the LV and do a single ventricle repair. Again, not ideal. So one other option here is to do actually aggressive commissurotomy and atrial switch. Or if the pulmonary valve is really, really small, we do atrial switch, but instead of this small valve having to get the whole cardiac output across, we do a Glenn, which transect the SVC, put it directly into the pulmonary artery, and then do a hemimustard. So we only have to pass half of the cardiac output through this narrow outflow tract with aggressive commissurotomy and accepting some gradient there. So again, this area is actually quite difficult, but luckily enough, it's not very common. So TGA. So is there a VSD or not? So if there's no VSD, that's TGA with intact septum. So does the patient have a conditioned LV or not? Is he early or not? Or so if the LV is conditioned, what do we do? Arterial switch. So if the LV is not conditioned, is deconditioned, So we either do a first stage with a band or shunt, band and shunt, and then wait for LV retraining, and then we do arterial switch, or we do atrial switch, either mustard or cyanic. So if there is a VSD, is there any protection for the pulmonary circulation, or is that pulmonary circulation unprotected? So if the pulmonary circulation unprotected with no LVH obstruction, is that an Eisenmenger syndrome, or is it still early? So if there's no Eisenmenger syndrome, we do arterial switch. So that would be a TGA with a large VSD, unprotected pulmonary circulation with no pulmonary vascular disease. TGA, VSD, arterial switch, and VSD closure. What if the patient is presenting late with established Eisenmenger syndrome? Keep the VSD and do a palliative atrial switch, leaving the VSD open. So if the patient has LVOT obstruction, is it dynamic or fixed? If it's dynamic, then arterial switch operation and do nothing for the LVOT. If it is fixed, so then is it resectable or resectable? If resectable, then resection and arterial switch. If it is irresectable, then you either do a Rastelli, maybe preceded by a BT shunt if the patient was very cyanotic early on, or go the Nikaido pathway. Okay? So this is the very big overall scheme. Do you get it? Do you have any questions? Okay, the difficult part has passed. So obviously you can notice that there are lots of arrows going into the arterial switch operation, and that's because this is the operation that has the best long-term outcome across all the other procedures. Otherwise, we try to go into the scheme and think what's better for this specific patient and when do we do that specific intervention. So if we go quickly through results, so the arterial switch operation, early mortality is something like 2 to 5%. Obviously, that has improved a lot from very early on, when that operation early on when it was described had a really high mortality. But then with improving experience, refining the steps of the operation, but also improving the cardiopulmonary bypass, anesthesia, ICU care, this has improved a lot. Survival after 20 years approaching 96%, which is excellent. Risk factors for early mortality was coronary anomalies. Some coronary patterns are actually very high risk for transfer, and so if patients have these types of anomalies, can get coronary ischemia and might not be able to tolerate that. Patients with hypoplastic aortic arch, again, this is not a rare entity, so they'll have to get also, in addition to the arterial switch, arch repair and long bypass times. Most of these patients had excellent functional status and quality of life, which is great. It was described that some of these patients had supravalvular pulmonary stenosis. So essentially at the site of anastomosis between the neopulmonary root and the MPA, this area would get narrow. This was a technical thing, and modification for the arterial switch operation using bigger pericardial patches have improved this incident, decreased that incidence. On the other hand, many patients develop new aortic root dilatation. So in some studies, up to half of the patients after 10 years. And patients with dilated aortic root tend to develop aortic regurg. So it seems like that, because when we do the arterial switch operation, we keep the root where it came from. So this new aortic root was originally the pulmonary root. And so it seems that the wall is not very well suited to maintain systemic pressure for a long time. On the other hand, this root has also been incised to implant coronaries. So this can also develop torsion in the distortion in the roots. Some of these patients will require reoperation for the root dilatation or because of the aortic regurg. 5% of patients develop late coronary stenosis or occlusion. Many of these are actually asymptomatic, but some develop considerable impairment of LV function.
Osteostenosis.
Related to the coronary transfer, so either the ostia where it was implanted or very near to it where distortion or kinking happened. So they do not develop atherosclerosis if this is what you're asking for. It is related to the coronary transfer. Freedom from reoperation after 15 years was 80%. However, it has been described that some of these patients develop neuropsychological deficits. Some had, they did not achieve well in schools as their peers. So they are not mentally delayed, but they are not as achieving as good as their peers. Again, this is the subject of many studies. Is that because of the hypoxia during the fetal life or early before operation, or is it because of the big operation and long bypass? But again, this was not very evident in other operations. Again, still subject of studies. For the atrial switch operation, they had 87% survival after 20 years. So that's actually quite good as compared to the natural history. 90% did not require reoperations. The major problems here were baffle obstruction or baffle leak. So we mean baffles where you baffle the SVC or IVC to the mitral valve, or the pulmonary veins to the tricuspid valve. So in the mustard, it's more common to get SVC baffle stenosis, while in the Senning, it's more common to get pulmonary venous obstruction.
Please can you repeat some details about the technique?
We'll give some hints about the techniques. So we're just giving a broad idea, and then we'll show images. So baffle obstruction, usually if they are symptomatic or causing back pressure, they can be dealt with using cath stenting, either balloon if the baby is very small, but stenting if he's older. But some actually do require reoperations. Or baffle leak, and this is essentially communications between baffles, so between systemic venous and pulmonary venous baffles, and this is the physiology of an ASD. Again, can be closed percutaneously or might require reoperations. Some patients will develop systemic RV dysfunction and RV failure, and this was described in up to 25% of patients. A lot of these had secondary tricuspid regurg. So like patients with dilated cardiomyopathy who develop mitral regurg, also patients with failing systemic RV eventually develop tricuspid regurg. Many of these have arrhythmia, mainly supraventricular arrhythmia, and nearly a fifth of the patients require pacing. And again, this was not significantly different between either the mustard or the Senning. So they both had this arrhythmia problem, and up to 7% of patients actually had sudden death. So the Rastelli operation, the ventricular intracardiac baffling. So the major problem here is getting baffle stenosis, either early after operation, which is obviously either the anatomy was not suitable with a small VSD or conal septum in between, or inadequate baffle. Or some of these actually develop late, even after they come out of the operation with good LV flow into the aorta. With growth, the baffle becomes smaller in relative to the patient size. And obvious conduit obstruction. Early mortality up to 7%, actually quite high. And after 20 years, almost half of the patients would either have died or had transplantation. So again, this is this is not ideal. And you can see this is actually worse than the atria switch. Some of the recent studies have shown better results, but the Rtswitch operation is not very benign as you might think. Late mortality was mainly because of arrhythmia, sudden death, and LV failure. So might be because of the buffal stenosis or because of advanced right ventricular failure that actually caused LV failure also because of the conduit obstruction. 15 years freedom from reoperation was only 20%, but this is expected because of the conduit degeneration. So we'll go quickly through techniques. Do you have any questions about selection, strategy, timing? If there's any operation that you do not understand, do you have any questions? Okay, so I'll quickly go through some of the techniques. So the arterial switch operation. So the main goal here is that we transect both arteries, the ascending aorta and the pulmonary artery. We switch these, and we transfer coronaries from the route that was coming from the right ventricle to be implanted into the posterior route coming from the left ventricle, so that you end up with LV giving aorta and coronaries coming from that route. So now we're as if looking from the front. So this is the head, the feet here, right and left, and we're looking from the front. So this is SVC, IVC giving right atrium. Here is right ventricle giving ascending aorta. You can see coronaries coming here. This is the rest of the ascending aorta. While the posterior ventricle, the left ventricle, gives pulmonary root, pulmonary arteries, and PA branches. So we transect both arteries. You can see coronary arteries coming from the facing sinuses of the aortic root. You also transect the pulmonary artery, and then we want to connect the posterior PA branches, connect that into the anterior ventricle. And so it's much easier if the pulmonary bifurcation gets in front of the aorta. And so we do the Lecomte maneuver. So here, the ascending aorta is in front of the PA branches. After we transect both, we get the pulmonary bifurcation in front of the ascending aorta, so that it just overlies the right ventricle. So this is the Lecomte maneuver. So you can see here that the pulmonary bifurcation becomes in front of the ascending aorta. And then now we have to cut out the coronaries. So we do not take the actual coronary ostia. We cut the whole sinus so that it forms like a button with the coronary ostia in the middle, so that when you transfer that, it doesn't get a lot of tension or kinking, tension, torsion, or kinking across for the coronaries. So now we've taken out the coronaries, transferred that into other incisions in the posterior root, connected that, and now we have defects in the anterior root, which will become the pulmonary, so the neopulmonary root. So we connect the ascending aorta into the posterior root, so coming from the LV and now having the coronaries. Then we get a trouser-shaped patch so that it can reconstruct the pulmonary root after taking out the coronaries from that. So the neopulmonary root. Earlier on, they used to get two small pericardial patches just as the size of the coronary ostia, put that, and then supravalvular pulmonary stenosis was common. And that's why now we actually quite oversized that patch, a lot bigger than the actual sinuses that were taken from the previous aortic root that will become the neopulmonary root. So after reconstructing that, trying not to distort the valve, and then we connect the pulmonary bifurcation into the neopulmonary root, and now it's easier since the pulmonary bifurcation is anterior after the Lecomte maneuver. And this is the final configuration. So you get the right ventricle giving the neopulmonary root with the two PA branches. The pulmonary bifurcation is in front of the ascending aorta. This is very unusual. This is not like the normal. while the posterior ventricle gives the posterior root, the neo-aortic root, with both coronaries coming from there. So, so if you do MRI, CT, or echo, you'll actually find this configuration where the pulmonary bifurcation is sitting in front of the ascending aorta. So this is the Lecomte maneuver. So just an idea about abnormal coronaries. So we've spoken about the coronary anatomy in the previous talk. But so we assume that, so if this is a right coronary artery coming from this sinus, so and we want to cut out the whole sinus so that we can transfer that into the other side. So if we cut here so that we can take out the whole sinus, transfer that into the other root, and then looking from outside, we can see that the other coronary joins this sinus, and then we expect that the actual ostia of the coronary ostium opens into this sinus. Actually, this coronary is intramural. It passes inside the wall of the aorta, crosses behind the commissure of the valve, and then opens into the other sinus. If we're not taking care, we can actually cut these, and then you cut across the coronary, which is a really bad thing. And that's why the intramural coronary is a really difficult situation. There are techniques to deal with these. I'm just highlighting the abnormal or difficult coronary patterns and how this can be very, very dangerous. So now we go to the atrial switch operation. So the atrial switch, this is the end goal. We want to reach this configuration. So before the operation, SVC, IVC opens the right atrium, right ventricle, which goes into the aorta, while the pulmonary veins, left atrium, left ventricle, pulmonary. And now we've given up putting the LV to the systemic and just accept that the RV will remain the systemic. So we want direct oxygenated blood to the RV while directing deoxygenated blood to the LV. So we want to create baffles from the SVC into the mitral, and this baffle would be joined by another baffle from the IVC, again both going into the mitral valve, while the pulmonary veins from behind these go to the tricuspid valve to open into the right ventricle.
Baffles, you mean artificial?
They're different. So different techniques use different things. In the Sanning, I just described that. We'll be using the atrial wall and the septum. In the mustard, we use pericardial patches. So this is the atrial switch using the Sanning technique. This was the first operation, first successful operation that was actually described to do total correction for the TGA in the 60s, really early on. I would consider this operation to be one of the most clever operations in medicine. Okay, so I'll just go through the steps. If you do not get that, you're not alone. Many surgeons do not get that. So here we're looking like the surgeon view. So this is as if the patient is lying on the operating table. So here's the head, here's the feet. We're looking from the right side. So SVC, IVC, open to right atrium, right ventricle, getting ascending aorta, while pulmonary veins at the back join the left atrium at the back, left ventricle, and then to give the pulmonary posterior. So now we'll just zoom in here where we do the incision and the operations. So this is where we're looking. This is the right atrium, SVC, IVC going to right atrium with the pulmonary veins at the back going to the left atrium. This is the plane of the atrial septum. This is just a diagram that I've drawn to simplify things. If you do not get this, you just ignore it. But this is as if we're transecting this, okay? Taking a cut section and looking from here. So if you take a cut section here, then this would be the wall of the right atrium. if you open that, you find the atrial septum with an ASD. And then if you open the right atrium, you find the valve, which is tricuspid valve. If you look through the ASD, you'll find the other atrium, left atrium, with pulmonary veins. There are 4, but we're just showing 2 in that cut. And this is the mitral valve. Okay? So this is as if, and this is as if we're looking into IVC end on. So if I cut here and look there, it's as if the IVC is end on. So we start by opening the right atrium, so an incision into the wall of the right atrium. So we've opened there, so we can see this is atrial septum with an ASD there. If I see a valve here, this is tricuspid valve, as if we're looking here. And then through the ASD, we can see there will be mitral and pulmonary veins will be there. Okay? So now we want to cut the atrial septum, but not excise it. We just create a flap from that. So we cut like from the 3 edges and keep the edge towards the back. And if this is the atrial septum is very deficient, we can put a small patch, so that we now have a flap of atrial septum. And when we actually open that, now the right atrium and the left atrium are fully communicating. And then after creating that flap, we actually cover all the ostia of pulmonary veins. So as if this is cut at a flap and cover these. So that all pulmonary veins now will be just covered into a closed chamber. There. So now close the excised most of the atrial septum and reflected that posteriorly to cover all the ostia, the whole 4 ostia of pulmonary veins, like here. And so now we have a big cavity with SVC, IVC, tricuspid valve, and mitral valve, while the pulmonary veins are now shut in a closed cavity here. And then we open this cavity to the outside of the heart. Just an incision of the left atria at this pouch into the outside. So we were having the incision from there. Now we turn that over and create an incision to the outside. Are you still with me?
Yeah.
Now we do a difficult thing, okay? So we connect this to there. Like that. So this to the edge of the excised atrial septum. So that the SVC and IVC are below this tunnel. So if we do this, now we cannot see the mitral valve and we cannot see SVC and IVC. So now the SVC, IVC are directed into the mitral valve. So SVC, IVC go into the mitral valve. Well, now the tricuspid valve is to the outside of the heart. And then we connect the free wall of the right atrium into that opening that we've done to the pouch here. So as if doing this. Like that. And then it's very, very clever. And now you get systemic venous blood into the mitral valve, while pulmonary venous blood to the outside pouch into the tricuspid valve. Okay?
So the pulmonary venous muscles is outside the heart.
Into the new pouch that is outside the heart. And you can appreciate that this is the narrowest point, and that's why pulmonary venous obstruction is more common with the Senning because of this. There has been modifications for the operation to avoid this, but will actually not complicate things further. So this is a technique to baffle systemic venous blood, SVC, IVC, into the mitral valve, while having the blood from the pulmonary veins outside that into the tricuspid valve. And we're mainly using free wall of atrium and the atrial septum. So this was the Senning. again, if you understand that, you're great. A lot of surgeons back then did not get this, and that's why Mustard described his technique a few years later to simplify the same concept. So with the Mustard, you end up with essentially the same configuration while doing simpler pathways. So this is, again, surgeon view. Head, feet, we're looking from the side, very similar to the previous view, opening the free wall of the right atrium. And then the whole difference here is that the whole atrial septum is excised, so that we turn both atria into one big cavity, and then we start dividing from the start. So now this is the right atrium open. The atrial septum is excised. So this big cavity has SVC, IVC, all pulmonary veins, tricuspid valve, and mitral valve. And the aim of the operation is that we want to direct SVC, IVC into the mitral while leaving the pulmonary veins behind that, giving blood into the tricuspid. So we select a patch. We use a different shaped patch, but that's the concept. And this is the end configuration. You get SVC underneath the patch, go to the mitral valve, IVC again underneath the other limb of the valve, the patch into the mitral valve, while the remaining cavity will direct the pulmonary venous blood into the tricuspid valve, and then you just close the atrium as usual.
Is this a pericardial patch?
This is usually a pericardial patch. Again, different sizes and different shapes, but this is the...
It grows with sedation.
Yes, yes. So if this is pericardium, it will actually grow. It will not contract. So the atrial function with the contractile function and things, they will not be normal. The reservoir function actually lost, but you get a growing patch, yes. And the setting, again, the walls were native, so they still grow. We have actually described a modification for the Mustard operation, again, to try to improve atrial functions. Essentially, the long-term outcome of the atrial switch, actually as compared to the arterial switch, are not that bad. Still, you get problems with the RV, but then there's also limitation into filling and cardiac output. Going into the details of this modification is out of scope of this talk, but I invite you to have a look at the paper. You end up, this is the new 3D model for the new modification with better atrial filling and contractile function. We've seen better hemodynamic result, but obviously you have to wait to see actual clinical improvement for that. So the Rastelli operation is essentially intracardiac baffling of the LV to the aorta while directing RV to PA with an extracardiac conduit. This can be a homograft, can be a tube with a valve, can be a tube without a valve, so anything depending on the situation. So again, surgeon view, we're looking from the side, head, feet, we're looking from the right side. We open the free wall of the right ventricle. This will be anyway the site where you connect the conduit. So, and then you can examine the presence of the VSD inside. So this is the VSD. This is conal septum. You might actually want to enlarge the VSD or excise conal septum to improve the pathway from the LV into the aorta. What's the important structure that passes in the conal septum? There's no important structure. So you can actually excise conal septum, but just notice that the pulmonary root will be immediately behind that. So you do not want to cut out across the pulmonary root, come out of the heart. So here he's just examining that the VSD size is big enough. And then instead of closing the VSD that way, you actually close the VSD this way. So if this is the aortic root coming from the right ventricle, instead of closing the VSD, you actually direct the VSD into the aortic root. So that blood goes underneath the patch through the baffle into the aorta. So these are stitches going around the VSD, then around aortic root, and then come back around the VSD. Then this is the patch. This patch has to have, at any point, the diameter would be at least the size of the aortic annulus, so that you do not get LV obstruction. And then after the LV is directed into the aorta, now we transect the pulmonary artery, close the pulmonary root, and now we have an opening in the RV, another opening in the PA. We connect the conduit across that. We use whatever conduit you'll select, and then connect to the connect that from the RV to the PA. So the Rev procedure is a procedure which is very, very similar to the Rastelli. Rev is réparation à l'étage ventriculaire, which is repair at the ventricular stage. So it is, again, conceptually very similar to the Rastelli, but without using a conduit. So here, again, it was very well described that the conal septum is excised in the Rev. Again, people started doing that in the Rastelli also, but it was first described in the Rev, so that you get unobstructed flow from the LV to the aorta. Then, again, the pulmonary root is closed as usual. But the important thing here is that the ascending aorta is transected. And then the pulmonary bifurcation is using the Lucon maneuver, you get the pulmonary bifurcation in front of the ascending aorta. So it's very near to the RV, so it can be directly connected to the RV without a patch, without a valve. Very similar to the transannular patch which we do with the fallow. And then the benefit here is that if you're not doing a conduit, if you're not putting a conduit, you do not have to wait till the patient grows older. So this operation can be done as a primary operation in the young without having to do a previous shunt. So, sorry?
Like fellow.
Yes. So here the PAs are connected to the RV with a patch anteriorly without a valve, like a transannular patch. So again, essentially very similar to the Rastelli. Open the right ventricle, excise the conal septum, check the VSD size is good enough, but also the ascending aorta is transected, if you can notice. And then cutting the conal septum, you should not go across the pulmonary root. Again, putting a patch, directing the VSD into the aorta, then doing the Lucon maneuver, getting the PA branches in front of the ascending aorta, then reconnect the ascending aorta again, and connect the RV to the PA, cover that anteriorly with a patch. So this is the Rev procedure, or the French way of doing the ventricular repair. Nikaido is the aortic root translocation, where the whole aortic root is taken off the RV, which is similar to what is being done in the Ross procedure. You take out the whole root from the RV, put that on the LV. There are some variations in the Nikaido. So let's assume that this pulmonary valve is not very, very small. So the annulus is good enough, but the cusps are fused, they are thickened. You can do a commissurotomy there, but then if this becomes an aortic valve, there will be a lot of regurg and significant stenosis. So it might not be very well suited for an aortic valve, but actually might not be bad for a pulmonary valve. Like what we do with the fallow, we actually do accept less than ideal pulmonary valves with the fallow, and this actually has better result than doing transannular patches with some degree of regurg or stenosis. So if the pulmonary valve is not very bad, we actually do not excise it and take this pulmonary root also. So you harvest the aortic root and you harvest the pulmonary root, and then you switch them. Put the aortic root on the LV and put the repaired pulmonary root on the RV, which is usually better if it is good enough, would be better than putting a conduit, an external conduit. And then this would be called a double root switch, which is not an arterial switch, double root switch, where you translocate both roots. So again, this is ascending aorta coming from RV. The pulmonary is coming posterior from the LV. So the whole root is taken, harvested from the RV. Usually people transect the aorta and actually take out coronaries and then reimplant them later, but these are different variations. So the whole root is taken from the RV, and then you can see the VSD and the small pulmonary annulus posteriorly. So this is the conal septum cut into the new pulmonary annulus. And then, so the pulmonary valve is excised. You can notice that this annulus is smaller, but since it's cut, you can actually put a bigger root, and then you cover the VSD over with that. So here is the aortic root implanted over the LV. So this is the VSD. If I put my finger here, I go to LV. Well, this is RV. This is the VSD. So the part of the root is attached into the previous pulmonary annulus, and the rest of the annulus is covered by the patch that closes the VSD. So you end up with a configuration like that. So this is the VSD patch closing the VSD, but also covering the rest of the root. And then you'll end up with pulmonary arteries that you want to connect to the opening in the RV, either directly or with a conduit, whatever. This is the big scheme. TGA, intact septum or with VSD. If intact septum, is the LV conditioned or deconditioned? If conditioned, then arterial switch. If deconditioned, either retraining with the first stage, then arterial switch, or atrial switch. So if the TGA with VSD, then is there any LVH obstruction, or do we have unprotected pulmonary circulation? So if there's no LVH obstruction, is that a late presenter or early presenter? If there's no pulmonary vascular disease, so TGA, VSD, no pulmonary vascular disease, we do arterial switch operation. If there is pulmonary vascular disease, Eisenmenger, we do palliative atrial switch. So do atrial switch, leave the VSD open. If there is LVH obstruction, is it dynamic? If so, then arterial switch. If not, so fixed LVH obstruction, is it resectable? If yes, then again, resection and arterial switch operation. If not resectable, then either Rastelli directly or preceded by a shunt, or the pathway of something like Anechoid. Thank you very much.